Okay, so tonight, thank you all for joining us. We are really excited to get things going here. But before we do, I'm going to quickly get into a couple housekeeping things and then we'll get going. So I am Haley Payne. I'm with the Missouri Dental Association. We're really excited to have you all. I'm going to introduce the panelists super quick here before they talk about what they do and where they practice and answer questions and all that good stuff. So we have Jessica Emmerich. She is the Missouri Medicaid Facilitator. Let's see here if I can gallery. So here's Jessica, and then we have Dr. Aaron Bumann, Dr. Emily Hahn, and Dr. Ron Wilkerson. So this town hall is recorded, so we will send that out tomorrow along with resources and things of that nature, CE information, all that good stuff tomorrow. And so you'll be able to do that. We're going to hear from these panelists, and they're going to answer some of your questions from the registration forms. We'll get into the Q&A after that, and then we'll wrap up just a couple minutes before 9 o'clock. If you have questions while the panelists are speaking at first, feel free to drop them in the chat or the Q&A, and then we'll get to those at the Q&A portion of the event. At this point, I'll let Jessica take it away.
Hello, I am Jessica Emmerich. Like she said, I'm the Dental Medicaid Facilitator. I'm with the Missouri Coalition for Oral Health. My position is to be a contact for providers to assist with provider enrollment, credentialing, and claim processing. I have partnered with the Missouri Dental Association and MoHealthNet to support dental providers as they enroll with MoHealthNet along with the managed care plans. So I am a point of contact that I can help you with how to enroll, questions about once you've enrolled, what do I need to do next, or with the managed care plans. So some common questions that I am usually asked are, what's the difference between fee-for-service and managed care? It is all MoHealthNet. These are all MoHealthNet participants. The only difference is who's paying for their services. Fee-for-service is going to be individuals with disabilities, seniors, blind and visually impaired, that small group. Everything else is going to be covered under managed care. These are health plans that have contracted with the state to provide these services. So it's the same items, same thing. I'm sorry, it's not the same coverage all across the board, but what MoHealthNet pays, the health plans will pay also. That includes families, kids, pregnant women, so on and so forth. So that's just a basic overview of what's the difference. If providers are interested in enrolling, they will enroll through Missouri Medicaid Audit and Compliance. You will go to their website. They have an enrollment form there. Again, if you have any questions about that form or can't find exactly what you need, you're free to reach out to me and I can help you with that process. And then once you're enrolled with MoHealthNet, then you will enroll with the managed care plans if you choose. They each have their own credentialing process. And again, I can help you with that process if needed. One thing I wanted to share, I'm going to put over in the chat. This is a link to the fee schedule, which has the new rates. Rate increase went into effect back in June. This is updated with the new rates. Once you click on that link.
Jessica, can you post that in there again? It's
Sure.
going to host and panelists, but I should have changed it to everyone.
Okay, is that one you can change? Because I can't change it.
There we go. Sorry.
There it is. Okay. So there's that link for everyone to see now. And that will take you to dss.mo.gov, and that'll take you to the fee schedule. You'll scroll down to the bottom and you can either download the fee schedule or you can do a full search. I highly recommend doing only the full search because the download is multiple pages. It takes forever to find anything. So once you click on that full search, you will click on dental, and then you can search for the code you're looking for, and that has all the information you would need for billing those. If you have more questions about that, Amanda Ferendorf with MoHealthNet does claim webinars where she can go into more detail about what you can bill, the prior authorization process, modifications, all of that through EmoMed. So that is a great resource for you. Let's see. There are a few other resources that I am going to give to Haley to send to everyone tomorrow. It's going to be about the fee schedule. The fee schedule link, and then the provider manual. The provider manual also outlines what services are covered for the adult dental, the limited coverage, and what's covered for everyone else. The prior authorization process. Any question you have, you can find the answers in the provider manual. But again, I can help with that if you need help finding something specific. I'm also going to include a link to the claims processing schedule. A lot of people want to know, when am I going to get paid? MoHealthNet has a fee schedule on their website that shows if you submit a claim by this date, this is when you will get paid. So right up front, MoHealthNet is telling you what you're going to be paid and when you're going to be paid. Two things you don't have to worry about. They also have a provider search. So if you're looking for a specialist or need to refer to someone else in your area, they have a website where you can go and you can search for providers in your area, so you have some resources to refer other patients to if you need to. So again, I'm going to send all those to Haley, and she will send all those links out to you probably tomorrow. And then if you have any questions, feel free to follow up with me and I can give you more information when needed. So that's about all. That's my role in a nutshell. So I'm going to pass it on to Aaron so he can tell you a little bit about his practice.
Great, thank you. We are thrilled to have you, Jessica. It's honestly like amazing to have an opportunity to have someone that you can actually go and ask questions to, because the three of us that have been doing this for a while, we've kind of found our way. Right? We did not have Jessica. And so we're excited that you all do, because it's really something that we're just really excited. And so with that said, I think I want to just kind of briefly touch on, how we got here. I think many of us have been practicing in Missouri a lot longer than I have. And Medicaid is a challenging aspect of the dental world all over the United States, and in Missouri included. And so for decades, the MDA and the MOAPD have been advocating for increased fee schedules at the state level. And it was really a perfect storm of money coming in from the federal government and right person, right time at leading like the health director's office, the state health director's office, that person was in an interim job, and he was actually the governor's chief of staff. And then he went back and took all of the information that he learned over his tenure. And, there were a handful of us that got to input on that with the state dental director. And so he took all that information back to the governor's office to craft this existing budget and this existing fee schedule. And I think the big thing that all of us were wondering, that we're advocating for it when it happened, is we're told, hey, this is going to be like a meaningful increase, right? And most of us that have been in the advocacy world for a while kind of hear 10%, 5% when we hear meaningful. And we got almost a doubling, right? And in some cases more than a doubling. And so it truly is a historic fee increase. And I can't thank the folks at the MDA enough, the folks at the state enough, people like Guy Deaton, John Dane, 1,000 other people that were really working on this to make this happen over the course of years and even decades. And so we're thrilled. I think most of us spent most of 22 trying to figure out how to tell everyone that this wasn't fake news, this was actually happening. And so here we are to tell you that this fee schedule actually does exist. We're all getting paid these fees now. And so this really is something that you can do in your practice and make it work. I'm a pediatric dentist. I practice in Kansas City, and we've taken Medicaid for a long time. That was a part of our practice's ethos. So we felt like that was something that was important for us. But we also understand that that's not the only thing that matters, right? Like you also have to be able to pay your team. You also have to be able to have a facility that's worth going to, and so all of those things cost money. And to have a part of your practice that was consistently losing money just wasn't tenable. And so now we have something that actually works, and we're really thrilled to be able to share our experiences with you tonight, to hopefully have it work for your office just like it does for ours. So with that, I'm going to pass it to Emily, and she's going to chat a little bit about how she does things.
So hi, I'm another pediatric dentist in St. Louis. I own my practice, opened in 2019, and I originally started at St. Louis Children's Hospital, where we only see medically complex kids, and most of that population was Medicaid. So due to my experience being at Children's, I learned a lot about Medicaid in Missouri. So just some background. First, there's Mo Health Net, so that's straight Medicaid. And like Jessica alluded to, not that many people actually have straight Missouri Medicaid. It's usually kids like that I see at Children's that are very medically complex. And there's some nuances, but most of the patients have one of the three plans. And there's Healthy Blue, which is through DentaQuest. There is Home State, which is through Involve. So you're going to hear patients whenever they call, they're going to say what their plan is, but there's a dental component. And that's a nuance that everyone should probably know. And the third is UHC community. And so a lot of those families may say, we have UHC, where it's UHC community. So those are the three plans. And so when I opened my practice, I was like, okay, like Aaron said, have the ethos where I feel it's my professional obligation to see the population that really has a lot of disease. So just a statistic, 80% of all dental caries is seen in 20% of the population. And so that 20% is generally the lower SES, which is socioeconomic status. So with that data, and also the number one unmet need of people with special healthcare needs and developmental disabilities is, you guessed it, oral healthcare. So I was like, I'm going to find a way to do this, and I'm going to prove that you can do this. So what I did is I chose to work with only certain pediatricians and take their patients. So that self-limited my scheduling. And so that is something that is different with me against the other two guys, is that I do have a limit within my practice, and I placed that limit before the rates increased, just because I wanted to see how it went, and I wanted to be able to keep my doors open. So my limitation is they have to be followed by a pediatrician within the building that I'm in. So that's it's 13 pediatricians, and that's something great. And one of the number one myth I want to put out there, you can limit what patients you take. The limitation you cannot have is what time of day. So you can't be like, oh, I'm only going to take Medicaid at 11 a.m. You can have discrimination in that way, but you can have limitations in the number of new patients you take, the number of your panel, and a lot of people do age as well. So some people say we will not take new patients based on their age. So you can create your own requirements. So that's something that I want to scream from the rooftops. At Children's, we only take medically complex kids. So there are limitations so that you don't feel like someone's going to, steamroll your everything. So just know that. Another thing is the question that I saw was no-shows. My thing is if you create an environment and develop a relationship with your patients, they show up. I think that there's been a lot of these patients have been burned before because they go to the stereotypical Medicaid clinic where they don't feel as if they've been treated like people. And when we as providers and our teams learn to just treat people like people, they show up. And so I'm sure each of us will speak a little bit more on that, but that's just my 2 cents on that. I do a lot of general anesthesia. We actually spoke about codes and things like that. My team has found pre-authorizations for Medicaid is substantially more straightforward than those who have private insurance. It's a lot faster turnaround. And what's interesting is straight Mo Health Net and UHC community, you don't need a pre-authorization, whereas the other two you do. So I don't do this day in, day out, but I know those nuances. They're not that complicated. Another thing is enrollment. This is why it is so nice to have Jessica, because when I first opened in 2019, it was me personally trying to figure out who the contact was from each place. And it was literally, I was chasing my tail because they would change who it was, but now we have Jessica. So please talk to Jessica to help you with the steps along the way. She's the perfect resource for that. And then as far as billing, the one thing that I think is really nice is I don't have to go for collections with my Medicaid population. So we can present what's best for the patient, and the parents don't have to say, oh, I can't afford that. I can present a treatment plan. We don't have to go through the fees. I don't have to feel like I sell dentistry, and I can do what's best for the patient. And it is awesome in that capacity. I originally, when I first opened, I limited the percentage of Medicaid that I would see a day because, again, the fees were so much different. But right now, the fees are significantly more than some of the insurances that I'm in network with, and I get that fee right away. I don't have to get it from the insurance and then collect from the family or do the background math. So because the systems so my staff goes directly through the portals to do all the billing, just because it's a little bit more simple. But for pre-auths and predeterminations, and for just to see what their enrollment benefits are, their timing to do check Medicaid is substantially quicker because they've learned to process it, and that's part of their daily routine, but it's actually more simple. Now, other states, not the case. So at the hospital, we work with other states' Medicaid insurances, and I will tell you it is not as straightforward. Missouri, however, is. So if you're talking to colleagues from other states, they're probably right. They're a mess. Missouri actually has their act together. So that's my 2 cents. I'm excited about this, if you cannot tell, because we have an opportunity here to prove that healthcare can be accessible to everyone. And thank you for joining so much. And so with that, I know a lot about kids, don't know anything about adults. So Ron is here to give that feedback for everyone.
Thanks, Emily. I'm Ron Wilkerson. I'm your legislative chair for the Missouri Dental Association, also MOAPD member. I'd like to give a huge shout out to Aaron because he's your legislative guy for the MOAPD, and he's doing a fantastic job. We wouldn't be where we are without him advocating, and the rest of you guys over in MOAPD too. It's a huge success when we advocate together and the things we can get done. Medicaid increases being certainly one of the biggest things of our agenda items over the past probably decade, if not 2 decades. I graduated back in 2008, came out this way. I'm right outside of Rolla, Missouri. And I've been practicing, been taking Medicaid since I graduated. Came into an office that was doing it whenever I came in. So I was fortunate enough to come into an office that was very well versed within the Medicaid system. This fee increase is huge. Definitely take a look at the fee schedule. It's not perfect, nor is any insurance or any other entity you work with, but we've definitely made some huge strides in what we've got from the state at this point. There's always concerns that this could retroactivate back to the old fee schedule. One of the biggest things, if you become a Medicaid provider and it retroactivates and your office can't accommodate it, you don't have to be a Medicaid provider indefinitely. You can stop anytime you wish to. When you look at the Medicaid population, as Emily and Aaron kind of mentioned a little bit too, you have a no-show problem, just like you do with any other insurance company or any other insurance patient, rather. I'm sorry. You can dismiss these patients. You can send dismissal letters. My practice does do that. It's used to be a lot more frequent than what it is now. I think that I don't think it's a weed out problem. I think it's people recognize that the care is there and they need to have some responsibility in showing up to these appointments. As Emily and Aaron both said, you know what you're getting paid, you know when you're getting paid. It's a very easy system once you learn the nuances of it. It's very easy to navigate. Pre-authorizations are very easy. You know what you have to have pre-authorized. You know what you have to have involvement-wise with the tooth whenever you pre-authorize our general anesthesia case. As Emily said, I take both adults and children. We used to see a huge pediatric population. One time our practice was probably 90% under the age of 20. We've seen a bit of a demographic change within our office with the advent of the increased dental benefit for the adults. So we're seeing more of a swing of that. I see both children under general anesthesia, special needs adults under general anesthesia, so pretty well versed with the anesthesia component of patient care as well. Overall, like I said, pretty easy system. You guys submitted a lot of very good questions, and I don't know if we have time to cover all those, but I'll finish up on a few that Emily and Aaron might not have touched base on. The oral surgery fees, those were not increased for extractions for both simple and surgical extractions. We're hoping further advocacy will get that. Periodic exams are currently not covered for adults as well. All things that we're still working on. Like I said, it's not a perfect system, but we're getting there. We're making headway. We're trying to get more access to care to this patient population. I personally enjoy it. My office, I like to think my office kind of orchestrates slightly organized chaos. I love it when it's busy. And if you take Medicaid, you're not going to have a slow day. There's always patients knocking at the door to come see you, from check teeth, from people that haven't been in from 15, 20 years, to the recurrent kids that want to get in before school starts or when they're on break. So you will certainly not have holes in your schedule if you take Medicaid. I think I covered most of the stuff there. So that's about all I got. That's my story. So it's not very interesting, but that's what I got.
I think I'll riff off a couple of things that both of you guys said. I think one of the things that people think of when they think of folks with a Medicaid benefit is a low literacy, like oral health literacy kind of quotient. But part of that is just understanding that a lot of folks have had really intermittent access over the course of the last forever. And so, it is a part of our professional life to, as we bring people into our practices, as we give them a dental home, what I've found is that, yes, you do have no-show rates, you do have attrition, but that's not really that much different than the other parts of our practice. Especially as you get people to understand, like, hey, this is something that I can partner with you. Like, it's not just healthcare as a commodity, it's healthcare as a partnership. And that's really what we're trying to do in our practice. And, like Emily said, you really have the option of giving ideal treatments, right? Like, you are all of a sudden the healthcare provider that at least I always wanted to be. Like, I don't have to sell treatment plans to anybody, right? Like, I just tell people what they need and then I do that, or I don't. And it really is an amazing feeling to be able to really help people with the need that they have. And as far as like some of the other, there was a question that was posed in the chat about, if you're in a suburban practice. I practice in Liberty, Missouri, which is kind of a northeast tier suburb of Kansas City. So we do have people that are driving from 1, 2, 2.5, up towards the Iowa border away, either referrals from general dentists or just people that couldn't find anyone else to see them. And so it can be challenging. Some of that is public transportation within the city that also can be challenging. There are resources for them. They're not always perfect, but they do exist. So there's resources for folks that are finding travel difficult, whereas those resources don't exist for people on private insurance. So that is something that is really a big benefit for people that are out there trying to find us and trying to get to us. And so, the other thing that was brought up about no-shows, and then I'll get off this because I know we've spent time on it, but some of you might have the habit of charging for no-shows in your office for your either cash pay or insurance patients. You cannot do that with Medicaid. So that is something that is different. So I want to make sure that's aware for people. But like Emily said, oftentimes folks are just looking for a place where they are treated with dignity, like real, actual live humans. And if you can provide that in your office, which I know that you all do on a daily basis anyway, then it really gives people a lot of, I'm a pediatric dentist, so I think I can say this. It gives people warm, fuzzy feelings. It does. It makes people feel good about themselves. And when they feel empowered, then they can make better choices. They start to follow some of the guidance that we're giving them, rather than the whole talk down at people. But it really is an amazing thing to see a family come back over the course of a year or two. You take care of some of their issues and then they actually start to get it, right? And that's not everybody, but that's not everybody in your private pay world either. So it's really more similar than anyone would think.
And something that I think people don't always realize, at least in the pediatric population, there's a lot of foster kids and foster parents who are really in need of care for their kids. And so not everyone fits into I think it's human nature to have a stereotype for sure. But oftentimes patients don't fit that stereotype. That many times the insurances allow for you have to sign it to reimburse for transportation. But those are resources that you can inform your families about, and they really need to work with their insurance. That's not your responsibility to find them a ride. And I think that's one of the things, is that it's all of a sudden you feel like if you're taking them on, you don't have to get your people who have other insurances rides there. It is their responsibility, but there are resources within their insurance that may not be there. So that's something to keep in mind as well. The one thing that I will say is that I think as more and more of us in the state do take this on, we're going to be seeing more carries. And I think that is, okay, I saw that in the chat. Thank you. The more and more people that we see, they're going to have dental caries. It is going to be potentially with kids more of an issue with anesthesia. So Aaron, if you want to talk to that a little bit, because Aaron and Ron and I have all talked about oh, great, we're going to see more people, so we're going to see more caries. What are our options? I actually had a conversation in the OR today with one of the anesthesiologists. He used to be the head of the residency program at WashU, and I said, can you please start accepting more? And he just laughed at me. So they are having a major shortage with anesthesiologists nationwide. So take it away, Aaron.
Sure. Yeah. So it's a complicated problem, and I think Emily just touched on it. Is that it's not just some of the things I'm about to talk about, but it is also a huge lack of providers in the anesthesia space, right? So it's, even if we get all of the things figured out, it doesn't mean that we have enough bodies to actually perform the anesthesia care. So there are multiple hills to climb here, but one of the things that we're working on with the MDA and the MOAPD, and at the national level with the AAPD and the ADA, is we're working on some different funding mechanisms for hospitals to be able to be reimbursed more appropriately for dental cases. So for those of you that are pediatric dentists, or for those of you that are general dentists that did GPRs and do hospital work, then you'll know that a lot of times dental gets pushed because the fee schedule favors having a medical surgical case go in front of a dental surgical case because of how we get paid. So we're really working to kind of even the playing field so that we get an equal chance, right? That doesn't mean that we're going to take over, a dental case over a trauma victim or something like that, right? So there's still going to be rules about how these cases are selected. But if we can get our fee schedule to an appropriate place where then we're on par with ENT, let's say, or orthopedics, then we can say, hey, we belong in this OR space just like every other surgeon. And this child's needs are not any less just because it's their teeth, right? These children are in pain. These adults are in pain. These folks with special healthcare needs, they need the coverage and the treatment that we can deliver. And so we're working really hard to help bring parity to that space for our patients. Yeah, and Ron, I don't know if you have anything to add to that, but that's that. And then there's also some more good stuff in the chat too. So
yeah, I just kind of going through and answer some of these questions on the chat. Sorry, as I can get to them here. No, I just would echo exactly what you just said. I think that's a very well-rounded answer on it.
We do have a question that I don't believe has been answered yet. It might not be one that you all know. I'm not sure. It was stated that there are 3 different Medicaid companies, MCOs, I'm assuming, which one has a contract with St. Louis Children's Hospital. Emily, do you know that answer? Oh, you're muted. You're still muted.
It was stated that there are 3 different Medicaid companies. Which one has we are in network. I don't with contract. So medicine is very different. And hospital systems are very, very different than say other things. So that's a St. Louis Children's question, not necessarily anything else. So I know hospitals negotiate. with their reimbursement with the medical fees. So that's totally different. But I know that like St. Louis Children's, for example, is in network with all three of the Medicaid plans and MoHealthNet. But I'm not speaking as St. Louis Children's employee. I'm speaking as my private practice. And I can state that I take all three of the plans.
And importantly too, and I know this was brought up a little bit earlier, but as far as like, you know, the three different plans, like let's say you were looking to get started on this, but you wanted to kind of do a measured approach, right? You can say, hey, I'm going to take MoHealthNet and I'm going to take one of the MCOs just so that I can learn that process. We can get really good at it. We can start to see how many patients are going to work in our practice, and maybe we'll have enough. Maybe it's working well enough and things are going great and we want to add another plan. You can always like stack it like that. You don't have to just, it's not a fire hydrant that you have to stick your face in front of and hope you don't get like blown out of the water. Like you can do things on a very measured sort of approach that makes sense for your team, that makes sense for yourself, that build your practice over time, just like you built your private practice, right? Like it isn't something that you have to, go full on right away.
And
I also, sorry.
Jessica, I want to be clear. Just because when you get your Medicaid number through, you do not have to take straight Missouri Medicaid. Is that correct?
Correct. You can enroll as a managed care provider only. And I also wanted to share that participants are able to choose which health plan they are put in. If they don't choose a plan, then they are automatically assigned. But if you wanted to only take one at a time, you could let people in your area know that, and they can choose and switch plans as they need to.
And that's where I would recommend, I mean, it's worked out great for me to work with their physician, because it creates the idea of a whole health home. And so due to this, I have fantastic relationship with physicians within children's, because I work there, but within the pediatric community, because if someone calls and they're like, hey, I don't get this, or hey, I think this kid has an abscess, they have my cell phone. And same thing when a family, hey, this family has just shown up, what's going on? The pediatrician can get social work involved. The pediatrician will tell me the background on a social story. So by creating a whole health home, it clears up a lot of pictures. And also it helps because when they don't show up for me, their pediatrician usually knows, especially if it's a continual habitual thing.
There's two things I'd like to touch on real quick. One would be worrying about fees going back to the old schedule. It's certainly always a possibility, but as Aaron said, the state has so many more funds from the feds and itself too. The Medicaid budget, the dental Medicaid budget, is a very small portion of the overall Missouri budget. So when they start looking at cuts, if they ever come back to where they have to start cutting back on the budget, we're very, very far down that pipeline. If they start looking at us, there's a lot of other issues going on within the state. It's always a possibility, but a pretty big unlikelihood to have that. One other thing I'd like to touch on too is there is the limited adult benefit. It certainly doesn't cover dentures, it doesn't cover root canals, doesn't cover crowns, things like that. So you do change your practice dynamic a little bit of treating these patients. You aren't always able to treat the ideal. But if you can get rid of the caries in these individuals, get teeth out that need to come out, stabilize teeth with caries, you never know when these patients may go off of Medicaid and end up getting a job that has great dental insurance where they can get crowns later on in life and be able to actually save these teeth for potentially stabilizing them for a year or two to having a restoration that will last 25, 30 years or more for them. So there's some little nuances with the adult population, but the kids, if it needs to be done, it's covered. And like Aaron said, you know what you're getting paid. As Jessica said, you know when you're getting paid, and it's really a non-issue. There's no co-pays. If you go in there and you have a deep lesion and you're trying to do a crown on a tooth, ends up being a pulpotomy, you don't have to go back and talk to the parent, get an estimate, and go through all that, where you can just let the parent know, hey, this is deeper, we got to do a pulpotomy along with it, and it's covered and you're going to get paid for it.
Okay, we have another question. So far with the new rate increases, have we seen an increase in Medicaid dental providers?
I will share some numbers with you. Right now, Missouri has 940 dental providers approximately. So that is slightly better than before the rate increase. There for a while, they got really busy with applications right after the rate increase. There was a big pickup, but since then it's kind of fallen off. So that's where my role comes in, to kind of try to get the rest of these providers enrolled. Because there's 940 dental providers in Missouri now. There are also 1,416 Medicaid patients. So that's a way out of line. These people need access to care. That is why we are pushing so hard to try to help these other providers with whatever questions or obstacles they have to try to bridge that gap.
Well, and one other piece of data that I think is important is that, every once in a while I'll have people ask me, well, we have federally qualified health centers, right? And that's a place where folks with Medicaid can go. So the most recent data we have, it's about 33% of folks with Medicaid that have acquired a dental service of any variety. And about 80% of that is being seen at a federally qualified health center. And that still left over 500,000 people without a dental visit of any variety whatsoever. And so, and based on the numbers that you were just saying, Jessica, that's probably low on the estimated side. And so the reality is there's a huge patient base out there that has a lot of need that, like Ron was mentioning, if you've got places in your schedule where you've got gaps, now you have something that pays a good rate, where you have people that you can take care of. You can start taking care of your whole community, and it doesn't matter if you're urban, suburban, or rural. We have Medicaid families in all of our communities. And when you start seeing those folks, you start to see different parts of your community come to light that you might not have necessarily seen before. And that has made me a better doctor. I will tell you that right now. Like, because when you see people from all different parts of the world and all different parts of the spectrum, not just the ones that we're used to running in, I think that really that does a lot for empathizing with people and understanding where they're coming from. And that's meant the world to me.
I will say from an MDA perspective, with Jessica's position, this is something that Missouri is kind of taking the lead on. States are looking at this and kind of seeing what we've done, and they're really intrigued. And so I think this is going to set an example for the rest of the country.
Something to speak on. I don't know if everyone's office has this, but we have a no-show or a cancellation list. And so we preach about this a lot in my practice. So parents are really good about calling in if they can't make it. Again, all about relationships and building that camaraderie. My Medicaid patients always come. Like because they found a health home. And so we go down our list and make phone calls. They're there to fill those spots. So it is, like Ron said, a fantastic, fill your seats. So I definitely recommend that.
To Susan's point, I know that, specialists are kind of one of the linchpins of this whole thing, right? Not just us in pediatric dentistry, but oral surgery, endo, perio, and we know that some of those fees aren't in a place where we're going to be attracting a lot of specialists at this point. So just because a good portion of the fees got increased to a really good number doesn't mean that we still don't have some work to do. And so I know Jessica's been working with folks at the state, especially on periodic recalls for adults and for extractions, because we all, for those of us that have taken Medicaid for a while, it is hard to find specialists, and we do know that those folks are very much in demand because sometimes they're outside of our ability to help them. And so it doesn't feel good when you're in a position where you're like, well, we could do a root canal, but we don't have anywhere to send you, so we're just going to need to pull that tooth that would otherwise be able to be saved. So we know that there's still holes, that we still have advocacy work yet to do, but it is definitely on our radar. As far as specific numbers, I don't know if we have that. Jessica might have that, but I don't off the top of my head.
I don't have a number right offhand. We would have to follow up with the state and kind of see what their numbers look like, but we definitely know there is a need for these specialties. So.
On the chat box, so I know that, so it's actually a lot faster and quicker for us regarding Dentrix software and submission of claims. So my private practice, I use Curve. We chose to do the portal because it's actually faster for getting it through. And we were basically told, it depends on the plan. So, but that's for Curve. At Children's, we do have Dentrix and they submit the claim through Dentrix. So I do know that for a fact. I know DentaQuest is the one through Healthy Blue. Involve also has the same, I forgot that code, the payer ID. You can pay it through your dental software typically. So, but I found that the portal is really simple and it's cleaner. So that's what I use in my private practice. I don't know what you guys do for billing, for submission of claims.
We use eClaims, and we use the same clearinghouse that we do for all our insurance submission claims as well. The MoHealthNet patients, the non-managed care patients, have become such a small part of the population anymore. I don't remember with them if we had to send hard paper claims, ADA claims with them or not. I think they were eClaims as well. Jessica, you might know the answer to that one.
Yeah, for the fee-for-service, they are using EmoMed to submit their claims. And from my understanding, it's a fairly simple process.
So when new patients call my office, particularly the patients who have Medicaid. So the first thing is that they all have different like provider notebooks. What's it called? It's directory, the provider directory. I believe mine I'm not in the directories for Medicaid, but people still do like call me. And we say we are a network for those who are providers within our building is how we word it. So we can say we are accepting new patients from these pediatricians. And actually it was a practice builder for some of the pediatricians within my building. Now they're not taking new patients because pediatricians are slammed right now. But when my building was still building up, it was a practice builder because they're like, we have, all encompassing healthcare. So, but that's what they say. They just say, we're only taking patients from pediatricians within our building.
Well, and even for those of us that are, limiting it or not limiting it, based on our physicians or referrals, we basically are just out there for anybody. But we do have a wait list, right? So we will schedule you, but we might not get you scheduled until September, or October, and so, and we do move people up all the time. When somebody cancels or fails, like what Emily was saying, the nice thing is you always have people that you could call and move up, or at least have the opportunity to, right? Whereas that can be harder if you don't have that built-in patient base. As far as staffing, I think people talk about the idea that like there's extra regulatory burden and therefore more staffing. We've taken Medicaid the whole time, so I guess I can't say if we've hired more staff because we take Medicaid. But with that idea, we have people that answer the phones, and we have a new patient coordinator. We do, because we're a pediatric practice and there's 4 doctors, we do have somebody that like runs our runs our surgery schedules and those kinds of things. But I don't know any pediatric practice that doesn't have those positions. And so I think it's something that is pretty easy to work into your existing staff profile. And once again, like you grow it over time. If you find, hey, this is really working out and financially it's something that works for our practice. And hey, by the way, we might need to hire another person and expand a little bit. That's the right kind of problem. And so, that's where I see, the staffing side of it for our practice.
I mean, I love that there's no need for statements. No statements need to be sent out. I mean, that's a bit of a burden off as well. There's no patient estimates. I still have patients sign treatment plans, but
Or collections.
and collections, you don't have any.
Right.
And I mean, I think that's the biggest thing is that you get paid everything at once. You don't get paid by the insurance, then see what the difference is what you've already collected. There's just those nuances and those time consuming tasks are no longer needed with Medicaid.
And depending on your billing and how you do your billing and what dental software you do, you can have those Medicaid fee schedules in your software to where the adjustments are all automatic, and it's very, very easy for your staff to put those checks in when they do come in. One thing Aaron mentioned along with kind of regulatory stuff with it, there are audits I mean, people have heard about in the past where they make them sound big, scary, and the government's coming to break down your door and shut you down. I've been through those in the past. They're all very manageable. They basically will go through and look through your charts. So they'll within a reasonable number. I think the last one from one of the managed care plans, I think they look through 20 or 25 of my charts. Basically went through to make sure x-rays are of diagnostic quality. The treatment that you had listed and you've submitted is reflective in further x-rays that were taken later. And I've had very little, I honestly had not any issues with audits that have come through before. I've been very easily managed with them, and we haven't had one for 7 or 8 years now at this point. So I don't know how often they're doing them, but when they do come, I mean, they're certainly manageable. They're not coming to make you feel like you're doing doing a substandard of care or anything like that. So those are very easy to navigate. And if you guys ever hit one of those, my number is always out there. You can call me if you have any questions on anything like that. Does anyone have any questions of basically how long is your staff up and running efficiently with things? I mean, how hard is it to navigate once you become a provider? I mean, those are kind of some of the questions that I've been asked before. And if anyone has anything like that, please shoot them out there on the Q&A pop-up.
The biggest thing is so there was a question regarding stopping some of the like pop-ups basically. So I did my training in Washington State, and there were some practices there that I don't think we're always doing what we wanted. You know, I think that we're always going to see some level of care that we're not okay with, and I think that's why we need everyone else to take it, so that there isn't an incentive where that is the only place to go, to where we don't see chop shops. That just takes all of us taking a little bit of Medicaid, and it's not a burden anymore. I think that's the thing, is that people used to call Medicaid a burden. It's not in Missouri. And I think if you talk to some of your colleagues who practice in other states, they will be shocked what an opportunity this is. And I want everyone to kind of reflect on what they said in their essay to get into dental school. I would be hopeful that many people said they wanted to help and care for people. And like, this is truly your opportunity. So if we don't take advantage of it, what are we going to say? Why aren't we helping others?
All
Not
right,
to guilt you.
time for a couple more questions, or one more question if anyone has one. Are there any final thoughts? Oh, here's one. Does reimbursement come in one bulk check, or is it broken down for each patient per procedure?
It's just like any other traditional EOB.
If our panelists want to give some final thoughts. Oh, another one, sorry. Is there a fee schedule listed that we can review and see how it compares to our current plan? Yes. Jessica had put that in the chat box, but we will send that out tomorrow morning as well. Any final thoughts?
Sure, I'll give something. You know, I really want to thank you all for being curious about what this is, right? Like Emily said, this is such a huge opportunity, not just for us in our practices, but for the people that live in our communities, and, you know, for folks that have been outside of the system for such a long time. And, you know, as we get people healthier in our whole community, then they're going to participate in our community in a more holistic sort of way. And man, I mean, what a privilege it is to be able to get people to that place. And I'm really excited to do that with Emily and Ron already, and with you guys, hopefully in the future as well.
I speak a little more too. Sure, why not? I've always taken Medicaid, and as at this point, always will. I really enjoy it. I enjoy the patient population, and it's always starts with the kids. You get those good, healthy habits instilled with the kids, and it carries on to adulthood, and then you can get generational dental education out of it. And that's kind of how I see my practice. And I'm on second and some almost third generation now with some of the Medicaid families that have been in 15 years. So, I mean, it's pretty incredible. The kids you took care of when I first got out of dental school are now bringing their kids in to see us. So it's really neat to that capacity. I know that happens with other insurances as well, but it's neat to see that population come through. And if you really hit some of the points home with the parents and some of the dental habits with the parents, you see that reflected in the kids. And it always sounds like it's a kind of a made up thing, but I can tell you it really does hold true within the population that we see.
I just want to say again that if you are considering being a Medicaid provider, or even if you're already a provider, if you have questions or if you're having issues or anything at all, please reach out to me and let me know. And let's talk through it and let's figure it out. Part of my position is to communicate those issues with the state so that we can get people enrolled now, but we can also kind of fix the process for people in the future. So we don't know there's issues unless you tell us. So anything at all, please feel free to reach out to me. That's what I'm here for. This is all my position is for. This is what I do full time. So reach out to me by phone, email, even texting, whatever is easiest for you. Just let us know how we can help.
Again, she's a big deal. Like, having this is a big deal. I wish I had you in 2019. Like, would have saved so much time. So thank you, Jessica.
Yeah, well, thank you all for our panelists. You guys have been incredible. And if any of the attendees have any further questions, someone can shoot them an answer real quick, or I'll keep it down, or I'll track it down and we can answer that at a later tomorrow. But thank you to Dr. Bumann, Dr. Hahn, Dr. Wilkerson, and Jessica for joining tonight. They're incredible. They all do such great work for dental Medicaid in Missouri. And just a couple reminders, there will be an email tomorrow for all of you who attended for the recording of the link, CE information, fee schedule, all that kind of good stuff. And yeah, so if you have any questions, and it'll also have Jessica's information, which is great. And then you can follow up with any further information you might need or questions. So thank you all very much. We appreciate it. Have a great night.